Populations Core 2026 seminar series of the New Jersey Alliance for Clinical and Translational Science. As always, please feel free to ask questions along the way, and we will be sure to reserve some time at the end of the talk dedicated to Q&A. It's my pleasure to introduce our speaker today, Arianna Campbell. Dr. Campbell is an emergency and addiction medicine PA with more than 26 years of clinical experience. She works in emergency and addiction psychiatry as well as buprenorphine access at the VA in Sacramento and serves as senior director and principal investigator for the Bridge Center at PHI and CA Bridge, a program for which she is the co-founder. She is president-elect for California Academy of Physician Associates and is a CE committee member and presidential task force member for ASAM. We are excited to have Dr. Campbell with us today and are so looking forward to this presentation. Dr. Campbell will highlight the rationale for direct-to-inject XR buprenorphine to improve access to life-saving treatment for opioid use disorder. She will review the results of a recent national survey comparing emerging practices across the U.S. Lastly, she'll review the algorithm that was recently released by the Bridge Center at PHI for Emergency Department Administration of XR buprenorphine and the evidence behind it. So, Dr. Campbell, I'm going to close my slides down and stop sharing, and over to you.
Great, thank you. All right, I will go ahead and share. All right, thank you so much for having me. I know I've met a couple people here at some various, presentations and some different things I've done. I've been collecting letters behind my name only because I'm a very curious person and sort of just a student of medicine, and I'm really curious about what people are doing across the country to save lives. And I'm very inspired by so many people. I know you have some heroes in New Jersey that I have learned from. And so I'm just really honored to be here today to talk to you all about direct to inject. This to me, I've been obsessed with because my patients need more ways of getting, of initiating treatment for buprenorphine. And so as much access as we can provide and innovation to get people to life-saving medications, it is a win. So I know, thank you for that introduction, Hannah. We talked a little bit about Bridge. So Bridge, we're called the Bridge Center at the Public Health Institute. We're a grant-funded nonprofit, really obsessed with teaching people how to administer medications, with getting people rapid access to medications. And we're just constantly thinking about ways that we can improve our healthcare system so that people get the medications they both need and deserve. A lot of the work we're doing nationally is funded by the Opioid Response Network. So I have to give them some kudos here. And they are supporting our network for emergency addiction treatment. And so we have a network where we're really trying to highlight and bring together experts from all over who are of the same mind, really trying to get treatment out there and connect them and elevate their work, and also lean into some of the innovations out there, and share those learnings. And so I'm here today. I don't have any financial disclosures. We already talked about what we're going to talk about today, so thank you for sharing that. And we're just rooted here in overdose is our number one public health problem. More Americans die under the age of 45, and so actually in some parts 55, die from drug overdose than any other cause. And when you think about that, you think about what we're doing about this, right? And what we can't do is just lean into systems that haven't worked or that haven't provided rapid access. We need to start thinking about this like we would any other life-threatening condition, where we need to have a system of care that meets the crisis at hand. And so that's what we're really trying to do here. And part of that work is providing access to medications in a way that people want and that is less harmful to them, and that also gives them opportunity to live the life that they want. So it's really, not only is this our number one public health problem, but we have answers to it. And we know that we've had, sustained increases in overdose deaths. And yes, we have seen a decrease in overdose deaths, and that is related. I mean, I know a lot of you here in the room, you're here because you're doing this work, you're interested in this work. You are the heroes, you are the reasons we're seeing decreased overdose deaths, and yet it's still not enough. We have to keep pushing forward so that people stop dying from preventable causes, including overdose. So again, joining the movement where we are obsessed with finding ways to help people live, to help people understand what's going on in their community and what's happening in the drug supply, and that there's treatment out there is really, really important. I'm going to mention a hero of mine, Sarah Wakeman, who I've had the privilege of working with over the last year. And this is a quote from her. And I think it's really important to like, though she's very eloquent, she's really good with words, and she is doing the work. And so this is actually Brian Hurley, another friend of mine, highlighted this quote, and I took this from him because the more I can get this out there, I think she has a really nice way of putting it. But I want to stress this last thing that she says. We have this urgent need, we have this opportunity for health systems and clinicians to commit to strategies to expand mood treatment. We do. We know that these are preventable deaths, and it's unacceptable for people to go untreated. Even after when they're accessing all of these different touch points in medicine. So I know, Rusty, you were just telling me, working in the carceral settings, that's a touch point. That's a point where we need to consider how to make it easy for people to get access to medications. And so it's just important that this is the mantra. This is what we all need to be following, is really thinking about the touch points in our communities and how we provide access to care. And also work with urgency. So we know that fentanyl use is an emergency. And I practice, you heard I've been practicing for 26 years. 17 of those years, I was told that opioid withdrawal is not an emergency, it's not life-threatening. And I addressed it like that. Oh, this is somebody else's problem. There's this whole other system of care out there that would help them. They should go to counseling. They should get into residential treatment. These are the things that I thought was normalized. Like should be treatment, not considering that the medication part of it is the number one life-saving part of treatment for opioid use disorder. And so, considering with fentanyl, with our drug market right now being really dangerous, Nab Dasgupta does a really great blog on drug supply and trends in overdose deaths, and I follow him because he really highlights some of the changing drug supply. But fentanyl, or what people think is a fentanyl, every use can kill. Every community needs a plan, and that is important to consider, and something that I stick with and try to get. We're really trying to give people the tools they need so they can develop plans in their community. But wouldn't it be great if we had a big, an overarching plan, right? A whole system of care that we're all a part of. Like we have systems for stroke and STEMIs, and we have, systems for trauma. We really need to develop something like that for substance use disorder care in general, and particularly opioid use disorder. And when we think about treatment for opioid use disorder, we need to meet our patients with the same urgency that they're seeking treatment. When they come in, this is what they're feeling. The minutes matter. We have to be ready. So when somebody's experiencing acute withdrawal, they initially start hurting. Some of our patients don't know when we prescribe opioids that one of the first things they're going to feel when they stop taking it is they're going to feel more pain, right? So they can even be duped into just taking more because they're just trying to fix their need of, treating their pain. And then they can get so sick, and their craving is just, I remember I was diminishing the power of craving earlier in my career before I really dove into understanding addiction and withdrawal. And that craving, people crave this drug like it's water, like, it's sort of their neurobiology, their system is disrupted. It's like hijacked, right? And their brain is telling them they need this drug like it's oxygen to breathe. And so we need to meet people in a place where we can help address this quickly and get them access to care in a way that works for them, to help them through this, because it's so hard for people to get to treatment. And my patients tell me this. Some of them they have so much trouble getting there, of getting to the point where they can get treatment. And we need to be ready, and they're, willing and ready to help them with medications that work. All right. So we're talking about, yes, I initiate people on methadone in my emergency department. And certainly am a fan of the treatment that works for people. And so I am also a fan of methadone. In fact, we're almost finished with an updated guide on initiating methadone in the emergency department. That being said, what we're going to talk about today is buprenorphine. Buprenorphine is something that, that is a Schedule 3 medication that we can, if you can prescribe codeine, you can prescribe buprenorphine. It's this partial mu receptor agonist. I know that there's a lot of experts here, so I won't dive too deep into it. I'll just, some highlights here, but we have these many different forms of it, right? We have the sublingual tablets and films. We have IV formulations, IM formulations. Subcutaneous injections are what we're going to talk about a lot today. And we have transdermal patches and we have, buccal films, et cetera. And there's naltrexone. I use a lot of naltrexone for alcohol use disorder, but most of my patients have not been successful in trying to get to naltrexone injectable. So I have very few patients who are given naltrexone for opioid use disorder. I am a very much proponent of patient-centered care. And so people have access to any of these things, and I will support them and give them avenues to the care that they want and deserve. But I do have a big focus on buprenorphine. And so when we talk about buprenorphine, just making sure we're all on the same page here, safely, effectively treats the withdrawal, the craving, of course, that starts early on and in that withdrawal process and prevents overdose. And the big things about buprenorphine that I always talk about are the ceiling effect on respiratory depression and sedation. And working in the emergency department setting, treating precipitated withdrawal, and I have given massive amounts of buprenorphine and upwards, in various circumstances, I've had somebody over 100 milligrams of buprenorphine in 24 hours, and he walked away after 24 hours. So I have seen the ceiling effect really play out at very high doses. But there's not a ceiling effect on analgesia. But the other thing we love about buprenorphine is its high affinity for the mu receptor, so its ability to block other opioids. But again, that creates some trickiness in initiating, which is why we've had to get creative with how we initiate buprenorphine, because if it is given too early, and somebody is not in at least enough withdrawal, or we haven't addressed, we haven't done a really good assessment of that patient, it can displace the other opioids. And those opioids, as you can see, that sort of teal line, they do all of the things, right? They have all of the mu agonist effects. And when buprenorphine has that ceiling effect, if it bumps off or displaces other opioids, that difference is where we make people feel sick and where they experience precipitated withdrawal. I guess we didn't make them feel sick, but the medication did. And when we only have a few different medications that are evidence-based for treatment of opioid withdrawal, that can be problematic because then people think they're allergic or they're terrified to start buprenorphine. And because this is such a safe medication, we don't want them to have a negative experience with it. All right, and we know that bupe saves lives, so reduces all-cause mortality by more than 50% over 5 years, and that's actually even if treatment's disrupted. So that whole starting over if somebody returns to use, I tell people, hey, gosh, even if we got 2 months of treatment, we're chipping away at that 5 years. So it's really important to acknowledge that it does reduce all-cause mortality, as does methadone. 1 year mortality after a non-fatal overdose, similar to if they had a heart attack. So my understanding of the need for treatment was flawed. I didn't understand that the mortality was so high after a non-fatal overdose, but Dr. Weiner helped us understand that when he published this in 2019. And then when we start people on buprenorphine, it decreases readmissions, minimizes ED utilization. This is from Grzinski. I also just recently published in a rural setting that when we had a navigator who doubles the likelihood of getting patients to treatment, that it reduced readmissions by 64%. 64%. That was actually for alcohol use disorder, opioid use disorder, as well. And so doing the right thing in emergency departments in hospital settings actually helps the hospital too. We also know that, a mentor and hero of mine, Dr. D'Onofrio, published this randomized controlled trial way back in 2015 about when we actually give the medication in the ED, not just send them somewhere else for it, that we massively increase the likelihood of that person remaining in treatment that is life-saving. And again, that ceiling on respiratory depression, I often talk it can cause some respiratory depression, right? It can slow some breathing, but there's a ceiling effect on that. And we've known that for a long time. We also know that high doses are safe. In fact, when we first started giving buprenorphine, we gave it in higher doses, and then somehow it got to like lower doses, which I just want to, sort of level display. Like we've been giving high doses for a really long time, and we do know that they're safe. Again, and when you look at the minimum respiratory rate, minimum oxygen saturation in these higher doses above, even above 28 milligrams, that we didn't see a big difference here. So we know that at high doses that buprenorphine is safe on its own, when not combined with other things. We also know that fentanyl made things tricky, right? Acknowledging that fentanyl is just kind of it's special or weird. It even just approaches the cell in a different way. It's lipophilic, and so it's wreaked some havoc here in terms of our patients, massive increases in overdose deaths, but also it's been trickier to get people into treatment. It's not just been buprenorphine, it's even just getting the right dose of methadone, right? A lot of our patients suffer in that process of getting onto medications for opioid use disorder that we know decreases their mortality, but fentanyl has made it just a different, a different environment out there in how we get people to medications. So, Dr. Andrew Herring is, a partner of mine at Bridge, and I took some of this from him. I really like how he categorized interventions to recover opioid sensitivity. So, we're talking about treating opioid withdrawal, but there's this when we if you dig into some of this really nerdy literature out there about it's really like recovering our opioid sensitivity, because when somebody is using fentanyl, we are just like they are, I always say, like, when somebody is taking high dose full agonist opioids, when you try to take a blood pressure on them, they're screaming. They're opioid, like it's like their body is finding a way to have pain, right? We all are creatures who, we're trying to survive, right? Well, pain is a part of that survival. And so when we quash it with these big amounts of full agonist opioids, your body finds a way to have pain, but we've kind of like pushed down all of these opioid receptors. So what we're trying to do when we're treating somebody with buprenorphine, when we're treating somebody, is we're trying to help them recover their opioid sensitivity. We're trying to, help them kind of rebloom, right? So the ways we can get people into treatment, there's really three different ways, and I mentioned the medications, but in order to get somebody on buprenorphine, we've historically given, they have to have a period of abstinence, right? So abstinence and some time to get them to buprenorphine so that they're in enough withdrawal where we can start buprenorphine so we don't precipitate, right? That is one way, and a way that we've been doing it at Bridge, for example, for a long time, where we say they need a COW score of at least 8 with 2 objective signs. You give them some time. They have to have enough time from their last fentanyl use, and then we can initiate them on buprenorphine, usually high dose buprenorphine. There's also been, you've heard of people who are sort of microdosing is something people have called it. Some of us don't like that term, but where people have been maintaining full agonist and then you kind of creep on the partial agonist being buprenorphine. Another way to do it is to get people to an antagonist, or, another way that, people have just administered naloxone when they've overdosed. That's one way that there's an antagonist, and then their opioid sensitivity is recovering. And then there's potentiators that can accelerate the tolerance recovery, and that's actually like ketamine or some adjuncts to help people get through the withdrawal. All right, so we're going to talk about abstinence plus time. So this is where we're trying to get people to clear some withdrawal. So it's usually like 24 hours of abstinence from fentanyl, specifically, and development of 2 objective signs, and then we would give them again rapid, like high dose buprenorphine. So that's our quick start. That's the buprenorphine quick start. We developed this at California Bridge. You'll see we say wait for severe withdrawal to start and look for 2 clear objective signs. We changed it from just a COW score of 8 because we found that somebody using fentanyl very quickly gets a lot of some of this more subjective stuff, like they kind of start moving around a lot, get pretty anxious and agitated, and so they can score an 8 based on that, but may not be ready for buprenorphine, and there's a little higher risk of precipitating withdrawal. So we look for 2 objective signs like piloerection. Yawning is a big one that we see, and we teach our patients also, if they're doing a home initiation or outside of a clinical setting, then we will teach them what to look for to start buprenorphine. But that's how we've traditionally done it. And again, we look for those objective signs. Goosebumps, yawning are 2 big ones. Some of the other ones, they're pretty reliable, but other things can cause them. So I can tell you, when I'm looking at somebody, they could be tachycardic and have dilated pupils because they're using meth to get through their withdrawal or use meth regularly. So the piloerection and yawning have a little more, they seem to be a little more specific for opioid withdrawal. So those are a couple that I look for. People, again, self-start at home. We know this. The other way to recover opioid sensitivity is keeping somebody at a full agonist and then creeping like that partial agonist on. So a lot of us have been trying this. So there's ways ways people have done this on the street is maintaining their fentanyl use, and then they take tiny doses of buprenorphine and increase it, usually over anywhere between 3 to 7 days. I can tell you outside of the hospital, it's just been challenging for people to like completely transfer over to just buprenorphine. I've just had a lot of trouble with that. And I think UCSF published something that it was that this it, we didn't have really great rates of staying in treatment when we were doing that. But it works for some people. If somebody says they successfully did that before and want to do it again, great. Ways we do that in the hospital setting is we might be administering high dose hydromorphone and then start ramping up buprenorphine, and that's what this looks like. We've put out some guidance on this where we do low dose buprenorphine initiation in the hospital while maintaining people on high dose full agonist. And I picture this picture, where we're really trying to bring people up on buprenorphine. Some people do it through patches. We could do it through injectables, which we'll talk about. Um, but let's talk about injectables here because it has been challenging for people to get through enough abstinence and enough time from fentanyl to initiate buprenorphine. It's been challenging for people to work on these microdosing regimens, and in my own experience, people have just not been able to quite, like I say, get there. So we have different formulations available of extended release buprenorphine. We have these weekly and monthly administrations. It's really important to look at this median time to max concentration. So what you see is with the XR Bup weekly, it takes them 24 hours to get to to get to those high serum levels. The half-life is 5 days. So it's kind of made this like perfect medication that many of my friends have recognized and have studied in terms of initiating buprenorphine because we can start it earlier on. And it kind of does some of that microdosing like on its own, but in a more reliable way. So that's been a big innovation. And actually, the ED Innovations trial that Gail D'Onofrio has been running, they did some early publication on this, and we found that there was low precipitated withdrawal rates. And this was something that a lot of people, a lot of patients preferred. So we consider those second generation, the XR buprenorphine formulations. There's also the monthly buprenorphine preparations. What's interesting is the monthly ones get to median time to max concentration 6 to 10 hours. So sometimes people will say, well, why don't you just go for the monthly? And sometimes it's because we can initiate it a little sooner with that weekly formulation because the median time to max concentration. And I have some charts I'll talk about that. And then we of course have our first generation Sublocade. One thing I want you to note here on the Sublocade, on that first generation Bup monthly is the mean half-life, 45 to 60 days. So think about that and it also has a median time to max concentration of 24 hours, but it goes pretty high dose, right? So that one, if I have somebody who requires high doses of sublingual buprenorphine or has in the past, that first generation monthly is really important actually because it has that long half-life. So there's different advantages and disadvantages to each one of these injectables. So this is an important chart, to have in the back of your mind. Also look at those injection volumes. With the 300 milligram first generation monthly, that's 1.5 milliliters. So people experience a lot of pain with that. So sometimes we go for the second generation XR buprenorphine because they experience less pain, there's less volume, and it's a little different mechanism for how it works. Pharmacokinetics. So I just like to put this up there so you can see sublingual bup at 16 milligrams, pretty common starting dose for me, for a lot of my partners. You can see that they get up there, they get to their max concentration, their max serum levels, they're at 1 hour. So it's really quick, which is great when somebody's experiencing severe withdrawal because they feel better, start feeling better in like 15 to 30 minutes. And, they get there at 1 hour. But if they don't have enough withdrawal, it also then can very quickly displace, right, the fentanyl. So many of us have seen some pretty hairy situations with precipitate withdrawal. So there's some advantages to being able to give somebody this medication. This is that CAM 2038, which is that was the sort of the research term when we were with the second generation weekly buprenorphine XR product, and that's a 24 milligrams. So you can see it's a nice ramp up over 24 hours, kind of the biggest ramp over that first 8 hours. So I'm going to talk, as promised, we did a national survey. So what I can tell you is a lot of people that I know were involved in this ED Innovations trial through the Clinical Trials Network through NIH. And So they've been giving XR buprenorphine 24 milligrams for a number of years. I think it's may have started in 2021, maybe 2020, 2021, I think. And so we knew a lot of people were giving extended release buprenorphine injectable products across the country. And then once we had this more available a couple of years ago, again, one thing I did, we did a recent program at Immersa, and I can tell you one of my takeaways, there was, I guess, two takeaways from it. One of them is I think everybody thinks that they care the most about their own patients. And how beautiful is that? Everybody's like, well, my patients, and I love that because I care deeply for my patients, and so do so many other people. And so we surveyed all of these people who care so deeply about their patients and are doing things to get them to buprenorphine. And we wanted to see what they were doing and how it was working. So we wanted to see, I actually run a little collaborative, a rural collaborative, and we started the survey at my rural collaborative of my partners who all care deeply about their patients in these rural settings. And they were initiating people on the extended release buprenorphine products. So we defined the survey as starting people with opioid use disorder who have either no or mild withdrawal. And this involves administering an extended release injectable buprenorphine formulation. So this is this is also defined as we are starting XR buprenorphine with no transmucosal buprenorphine lead-in. Like there's no lead-in, you are just giving them an injectable product. And we wanted to see, again, what a lot of our colleagues and friends are doing across the country. And so we knew that direct to inject buprenorphine was happening, not just in these CTN sites. It was happening with a lot of our rural partners who just can't get people onto sublingual buprenorphine and have the injectable ready at hand and had patients who wanted to initiate it. So we know that there's been potential to expand treatment access, and many of our patients were telling us this is the best way they've ever initiated buprenorphine. So we know it can be used in patients with low or no withdrawal. We also know that our highest risk patients are people who just can't get there. um, when they come in, they just can't get into enough withdrawal that we can get them there through direct to inject buprenorphine. So we can gradually, those, like I showed you those serum levels, they just gradually increase over 24 hours with that weekly formulation, decreasing their risk of precipitate withdrawal. And so this is definitely one of those cases where we're meeting the needs. We're meeting that urgency of our patients who come in desperate for treatment at the moment that they have to engage. Because I can tell you when I have somebody who comes in, I had one of my friends, one of my colleagues call me and had somebody so desperate who's just super high risk, overdoses all the time, right? Super high risk and can't quite get to the sublingual product. And she said, how do I get the injectable in hand so I could get, she would have benefited from this. How do we do this? And so we're coming up with a system for her. But you want to meet people where they're at when they are ready to engage. And even sometimes we give the monthly formulation, and we found a lot of our partners were doing this because a lot of our patients, especially austere rural environments, a colleague in Alaska says people fly in, you got to give them the monthly injectable. How can we do this in a safe manner, educate our patients, and do this in the way that works for them? So yeah, again, we can use this in people low to no withdrawal. So it has the potential for vastly improved adherence. Again, set it, forget it mentality. And a lot of my patients do struggle with the taste of the sublingual medications. We know that there's some dental issues, mucosal irritation. Um, and then we've also, in pregnancy, sometimes pregnant in our some of our pregnant patients, the taste can be worse. They have nausea, vomiting. So this has been an advantage in some of our pregnant patients as well. Just increased convenience. A lot of our street teams this has been the way, right? One of my, there's street teams both in LA, in Washington. Richard Waters has been leading some work there that's been really innovative and getting people to street initiation. And we can start this in any withdrawal state. So including when they're not in withdrawal. So just truly meeting people where they're at. Some street teams in San Francisco who are doing this. And I know on the East Coast, I know New York City, we have some partners at Montefiore and at On Point who joined us in this collaboration to look at direct to inject buprenorphine. So again, these can be low complexity starts. In the emergency department setting, it just makes it really easy to administer, and it makes it optional to give a prescription. You can just give them an injectable and they're on their way. All right. And so some of the challenges, however, can be that there's pain, itching, redness, lumps, needle phobia. It's funny. I had a patient recently who said who I was going to initiate on buprenorphine injectable who was struggling. Was requiring high dose of buprenorphine, and so we were talking about injectables, and she said, "Well, I'm an anti-vaxxer," and I said, "Well, this isn't a vaccine. This is an injectable." And she wasn't afraid. She didn't have needle phobia. She was afraid of other things, but this was a way, and this has been life-saving for her. She was able to get an injectable and sometimes take additional sublingual, which has helped her get through it. Um, and then some of the challenges can be REMS, limited specialty pharmacy distribution networks. This is something we're working through right now. And please come to me with any solutions or barriers because we're running a survey right now. And our next challenge is that we're really trying to help people find access to get these in clinics, emergency departments, hospital settings, how we can really meet the challenges of getting the injectable buprenorphine products on formulary because cost is a thing. And there's buy and bill and bill and buy. And these models make my head explode. But prior authorizations, grants sometimes are required to support the cost of the medications. All right. So when I look at time to max concentration, what I do want to tell you is that it's highly variable. This was news to me, right? I was like, well, this is, when I give, you see the XR monthly product, that's the second generation product, the 128 milligrams. Look at the variability in max concentration. I just had a colleague reach out from Hawaii who had a patient who was just needing to come back sooner than the 28 days, actually on the 300 milligram dose because it just wasn't holding them. And I showed you the average median, it's the half-life is really long, right? So hypothetically, this person should not need an earlier dose, right? You can say, what's going on here? Just know that it's highly variable. So what I suspect is that this patient was somebody who just had lower plasma volumes and was kind of in this lower level. And so believe your patients. So and then some people, it may be like way too high. So just know that when we get into these monthly products, that max concentration is highly variable. Another reason we like the weekly product when people say, why are you giving weekly rather than monthly in some of your recommendations? It's just a little more predictable in that concentration. So the way that you can just see yes, there is changes high and low, but it's a little more predictable in time in terms of that, bringing up those blood levels, right, over that first 24 hours. So just know that we have kind of a more predictable on-ramp to that buprenorphine in the weekly products there. All right, here's a survey. So this is what was so fun is we got 43 responses from people who, again, when we defined the survey, we wanted people who were administering buprenorphine XR injectable products without a lead-in. And so what are the practice settings? There's most of our people were actually from clinic settings who were doing this. We did have people from the emergency department. We had some people doing this inpatient. We have street medicine teams there, and then we had some other settings other different settings, and some of those were carceral. And actually EMS, we had some participants who were from EMS who want to do direct to inject buprenorphine in EMS settings. All right, and so when we were looking at the COWS threshold, so what we asked people, what is the threshold? Like, what is the COWS score for you to administer buprenorphine? And you can see tied there is a lot of people, and again, a lot of our participants were from clinic settings, said there's no threshold, meaning if somebody comes in and they want the injectable product, I'm not going to have a threshold because I have to meet them where they're at. I will talk to them about risk versus benefit. The COWS, many, just equally people wanted a COWS score 4, and that's been studied. Like that is the one that we have a randomized controlled trial. Again, this is Dr. Herring, that's Dr. D'Onofrio who's leading this with Dr. Herring and multiple sites across the country. I think it's 28 sites across the country who have been doing this to a COWS of 4 because they have very low, I think the precipitated withdrawal rate for a COWS of 4 with 24 milligram buprenorphine is 0.6%. So very low precipitated withdrawal rates. And then some were waiting for higher COWS scores, as you can see in this response. And then we also wanted to know what is your COWS score based on what your setting is. Like we wanted to tease this out a little bit. So you can see in the clinic setting, it was equal no threshold versus a COWS of 4 to 7. So many were still following the guidance from that randomized controlled trial. And then, less people were waiting longer in clinic settings, if people were that sick. Emergency department, there was definitely more people who were waiting for that COWS of 4 to 7, but some still had no threshold. Inpatient, definitely they had a more preponderance for higher cow scores, probably because they have the advantage of being able to monitor people and give adjuncts. And then in street medicine, definitely the no threshold. One there and multiple other settings, those are like EMS settings you can imagine might have had no threshold. Um, all right. And then time, we wanted to ask people about preferred time since last opioid use. Were they requiring a certain amount of time from last use before they started the direct to inject buprenorphine? And you can see there's a lot of respondents who did not give a specific time. In fact, I can tell you our partners at On Point in New York City were preferred people to be continuing to use right up until they gave injectable buprenorphine. They do have some advantages because they are able to monitor, watch people as they're using, which I think is really helpful. But they've also told us they did this outside of that setting too. So just they really they found a lot of they're big fans of direct to inject buprenorphine. But yeah, some preferred 6 to 12 hours, but you can see the majority preferred 12 to 24 hours since last opioid use, and then others wanted more time post overdose. Immediate post overdose, there were a small amount of people who were giving injectable buprenorphine immediately post overdose. All right. And then which is the formulation that that we asked people, what are their preferred XR buprenorphine product and starting dose? And definitely the winner here was the Brixadi 24 milligram weekly. And that's probably because it's been studied, right? But you can see some of those advantages were that predictable on ramp there. But we also did have some people, then the other products were much, much lower, though I think Dr. Waters' paper could, he was using their group was using some 8 milligrams weekly, which I have actually started using. So we did the survey before we had that published article. And a little bit during when it published, but and then you could see some people were doing the monthly injectables as an initial direct to inject, and some people just gave what they had. So that's at either mixed doses. All right, and then you can also see preferred XR product by practice setting. So what are people giving depending on their practice setting? Like, okay, you could say that might work in one setting, but not another. You can see that the weekly, the clinics preferred the to initiate with the weekly, but then you can see there's a lot of them who did monthly, and it was actually a lot of Sublocade that was being given when they were initiating people in clinics. The ER, when you look at the weekly and monthly, you can see that definitely the weekly wins, but there are some people split between the Brixadi and Sublocade monthly, and a lot of this had to do with what was available on formulary, and then inpatient, you can see that split there as well. Our street medicine teams definitely and this probably had to do a lot of the refrigeration requirements have been removed with Sublocade, but I mean, not completely removed, but our street teams seem to be using Brixadi much more commonly, and some of the other settings were split. All right. And then, this was fun. So when we talked about whether people were asking people to abstain post injection, like when we give the injection, are they telling people to stop using fentanyl? And it was split right down the middle, right? So half were telling people to abstain, half people were telling people to use their supply as needed. So definitely split down. This is usually an informed conversation I have with patients in terms of what their comfort level is, because I do have people who I'd say my practice is split down the middle too, because I've said people who said I'm never going to go see my dealer again, and I certainly don't want them to encourage them to do that. So this is split down the middle. Supportive medications, this is where people duked it out. So, and I'm sure there's some people who could tell me some things that they like about how we can support people during their withdrawal period. But definitely the alpha-2 agonist one in terms of supportive medications that people prescribe if they're doing direct to inject buprenorphine, closely followed, then there's ondansetron. I like that the people really fought it out in terms of which supportive medications. Is it clonidine, guanfacine, tizanidine? There's very passionate people in this field who have a preference for one. And guanfacine, I learned a lot about. People are very passionate about that one. But yeah, on ondansetron, some hydroxyzine for sleep, NSAIDs, etc. I'll be honest, I typically actually just ask patient what they usually experience and then try to meet their need. And then, reported contraindications, most people said there was none. So recent methadones, there's some said pregnancy, but most people said there was no specific contraindication. Some people said buprenorphine allergy, though we do think that that's exceedingly rare. All right, and then are people prescribing additional sublingual buprenorphine? So who is doing what? And you can see that there's a lot of people who said no sublingual buprenorphine. They just give the injection and send them home. Because there's a lot of people who say things get confusing. And then if somebody takes that sublingual buprenorphine in those first 24 hours, they take away that nice steady on-ramp and they just bump it up, right? And can precipitate withdrawal. So it can get confusing. So many people don't give sublingual buprenorphine. And but in those who were giving sublingual buprenorphine additional, you can see if with the 8 milligram weekly, many were giving sublingual buprenorphine, some with 16. Very few were giving it when they were administering the 24 milligrams. And then there was some unspecified answers. All right. Now, when we asked how are you prescribing the sublingual buprenorphine, if you've administered XR bup, again, we have respondents who said they just don't give it. But when they were giving it, most people said they were giving the 8 milligrams TID, PRN, and then there was other fixed dosing schedules. Um, so we through all of his guidance and Andrew called this game of algorithms. We had everybody come in with their algorithms and what they were doing, and then we tried to land somewhere. And where what I can tell you is when we developed this algorithm, we base this also on the randomized controlled trial. Like we have seen a very low precipitated withdrawal rate with this randomized controlled trial in the emergency department setting. So we named this emergency department because this is the highest studied environment for direct to inject buprenorphine. But we did take into account these different practice things, and we landed it with some themes. And so yeah, it's a front and back page. So some of these asterisks, there's a back side which talks about these a little bit more as well. But without complicating factors, if you can look at somebody and see that they're visibly uncomfortable from withdrawal. So how we define this is a cow score of 4+ after 6+ hours of abstinence. So we thought those two things were important, and they accept XR. Then you can go straight to that 24 milligram weekly product. And then we just discharge with return precautions. And we included that so people can picture how it ramps up there. And, return precautions are if you either overshoot or undershoot it, or if they experience buprenorphine induced withdrawal. So we're trying to change the name a little bit of precipitate withdrawal, I'll be honest, because it gets confusing and some people are experiencing a massive amount of anxiety because they're so afraid of it. So I've actually, to my patients, I stopped calling it precipitated withdrawal because it sounds scary. Big words sound scary. I just tell them, hey, if you have a rocky course, this is what a rocky course can look like. If you kind of have a rocky course with initiating this, you can take these medications. If it's smooth, great. And if the rocky course kind of gets real rocky, that's what this can look like, then come back. That's how I describe it. And I think that's really helpful for people so that they know that, hey, things can get a little rocky, but there's treatment available. Um, if you want to dig into this more, this is just a blown up view of that. And again, really making sure, like when we talk about some of the complicating factors, like no complications, this is what we're looking at. And pregnancy, this is actually can be a big win in pregnancy, but it definitely is a risk benefit discussion. And we do consider risk of untreated OUD generally higher than the risk of XR buprenorphine, but there's only some limited studies. But many are administering this in pregnancy. Again, when we start this, now XR bup does not mean the team should delay follow-up engagement. So we definitely want to make sure people have warm handoffs and good follow-up with XR buprenorphine. We've talked about this a little bit, but this is what, we're also getting people usually to follow up within 1 to 5 days. And this is why. So I like to picture this with my patients is like, we want to get them, to this nice steady state. And then within 1 to 5 days, we can bump them up with a monthly injectable. So it's a 1-2 step. So again, we're recovering that opioid sensitivity. So there's a lot of information about this, about beta arrestin recruitment, if you really want to get into how we recover opioid sensitivity. But we can get to good efficacy, that full where buprenorphine is doing the magic, and we want to get them to that monthly injectable, usually within 1 to 5 days. So yeah. Now, I know I was asked to talk a little bit about precipitated withdrawal. So I just want to stress that precipitated withdrawal is very, very treatable. And in our experience with the long-acting injectables or these XR bup formulations, I think, we can have different theories on it, but, I think one of the problems when somebody precipitates withdrawal is when people stop giving the buprenorphine. it gets really tricky, right? Because if you stop giving the buprenorphine, now they're just experiencing sort of a downward trend on the buprenorphine efficacy while they're experiencing more withdrawal, right? And then you bumped some of that full agonist off, so it just gets really messy. So what we first want to make sure is that we get there with the buprenorphine, like because that is going to win, right? We know that that is going to win. So if somebody comes in, and this is important, in fact, for that randomized controlled trial, they defined this as a severe sudden worsening of withdrawal symptoms, like an abrupt cow score increase of greater than 5. So this isn't just like they're kind of like slowly getting worse. This is abrupt. So again, in a significant sudden increase in a cow score of greater than 5. So make sure you have the definition of it right. And then when we see that, I always say people are already there, so we want to fill their cup with enough buprenorphine. So we act very quickly, and we typically give the 16 milligrams of buprenorphine and a couple milligrams of lorazepam to help. And then we might give them about 30 minutes. And if they, a lot of people do improve just with that and can go home. If they do not, we actually give them more buprenorphine just to meet that need because we've already gotten there, right? They already precipitated. And then if they continue to experience severe withdrawal, these are people where it's okay to admit them. This is we've already talked about this is a high mortality condition. Medications are life-saving. And so if we need to support them to get them there, then do that. And there's a lot of things we can use to support them. Again, it was like sort of Game of Thrones, game of algorithms when we were talking about what people liked for these adjuvants. When a little pearl is I started giving pramipexole, which is like a Parkinson's agent, because what I found is I could make people really comfortable with some of these other adjuncts, but they were still like moving around a lot, kind of in a weird way. And that was making them uncomfortable. So when I gave Prami, they would feel better. And by the time I got some of their enough buprenorphine, etc. But I will tell you the magic in here is I more quickly than this will go to ketamine. And there are some formulations that people have given outpatient too, but ketamine has been pretty magical to get people through rocky courses. So just know that that's a favorite. And if somebody's really having a rocky course, don't be, this is when we're monitoring people. Like, we say escalate level of care. This is in the emergency department setting. I've had people on ketamine and fentanyl drips, and this is rare cases. There's maybe two a year, but we get them through. I always say support them like it's really complex, severe, terrible pain. And we support them until we can kind of get them there with the buprenorphine. We had a 100% follow-up rate for our precipitated withdrawal patients because we did a good job of supporting them. Just so you know, this is Josh Luftig led this survey, the hackathon that we did, and we've made everything available to anybody who will listen. So you feel free to use this QR code, and you can look at how we're thinking about this, our guides, our algorithms, literature, prescribing info. We have a lot of literature to back all of this up. You can take this slide deck and present this on your own. We have our slide deck available. We have people who are chatting about, we included our very robust, spicy chat when we did presentations on this. We have a webinar that we've done on this, and we actually have the survey itself that you can look at. That's really just fascinating. So we're really just trying to be open access, and so people have access to these materials so that they can, do the right thing. All right. I talked a little bit about all these different interventions to recover opioid sensitivity. Just know that when we say antagonist, I know that there's some people who are initiating through naloxone. I'm not a big fan of that, but sometimes people are administered naloxone to save their life, and that there's a lot of people who are administering buprenorphine after naloxone administration, and it's a great time to do it. And some are even looking at the injectables. We did know that when buprenorphine is administered in EMS settings, that people will engage in treatment. So just think these are some of our highest risk patients, and this is an opportunity to get them life-saving treatment. So we have algorithms for that. And then just a quick word on potentiators, and I'd like to take some questions. And so I'll just say that I talked about ketamine. Ketamine is a great adjunct when somebody's having a rocky course because it can block some of this hyperalgesia that people experience in that when they're recovering sensitivity to opioids, they can get hyperalgesic. So ketamine can really block some of that, and it just can promote some of that recovery of the opioid sensitivity. We think it even potentiates the buprenorphine a little bit. So, and I do want to mention, in that precipitated withdrawal, that it still is uncommon. I can tell you, I can remember, I can picture the faces and how they moved and how I felt at the time when precipitated withdrawal happened, but it still is pretty uncommon. And one thing that Gail D'Onofrio has talked to me about this, and one thing she has said has been, hey, she's had very few precipitated withdrawals, and she just said, Educate your nurses. That's probably been what she thinks is one of the like, one of the confounders here, right? Good nursing education on what opioid withdrawal looks like can be very, very helpful. And so I actually just did 10 different skills days for the nurses at the VA to teach them how to identify opioid withdrawal, talk about cow scoring, and things like that, because we're doing direct to inject buprenorphine starting there this month. So anyway, I just please, precipitated withdrawal is uncommon, but a lot of this has to do with being able to assess the patients. I did want to say we are starting to do, and I'm doing this in my addiction psychiatry setting, direct to inject to a cows of zero. That's what Dr. Waters' paper talks about. They're doing this in Seattle. They're doing like 816. They've changed this up a little bit, so they may have changed this a little since last time. But this was what a lot of people duking it out talked about, is going like 816 to 128. And you can just kind of see why. We tried to look at like those serum concentrations. This is just an emerging practice, but I wanted to include this because this is how we're thinking about how you can kind of divvy up patients, because in reality, people don't come in cows of four into the clinic. So what do you do if they don't? What are the options? And what's the option if they come in and they're really sick, right? We don't want 24 hours to ramp it up. So we're trying to give guidance in all of these different areas of how we can manage patients and really meet them where they're at in whatever state they're in, so that we can get them onto injectable buprenorphine. So this is just an emerging practice. It's not studied. We have some like case-based studies that have helped us make this, but we don't have a big trial. So anyway, that's it. I appreciate your attention. Would love to entertain any questions, and I'll stop sharing.
Anyone can kick us off with questions. I'm sure there's a few people here who'd like to ask questions or
Yeah,
comments.
I would love to if I could jump in.
sure.
Thank you so much for this presentation. I really learned a ton. I'm Jennifer. I'm an instructor and leading a pilot study based in the RWJ health system, which recently-ish, couple years now, made a huge system level initiative around bupe prescribing in the emergency department. And so the pilot study at this stage is really learning from providers about their experiences and mostly qualitative interviewing with them. And a theme that's come up, well, I guess two parts. So one is we found that prescribing rates increased, but administration has really remained flat.
Yep.
And from our interviews, what we've heard from providers over and over is that they really hesitate to administer. They really have this COWS score of 8 in their head, and that most patients are not good candidates for direct administration in the ED. But what I'm getting from your presentation is that probably most people are. So
Mhm.
am I misinterpreting your
No.
presentation, or can you say a little bit about how you think about provider education in this context?
Yeah, you're describing exactly why we're doing this. So it's funny, actually. I don't know if Drake Hanfrick, she's here. She's EMS paramedic, and we talked about. It was funny when we looked at cow scores for EMS for administration of buprenorphine, when it was like lower. Everybody had a cow score slightly lower than that. So, because they were afraid to administer it. And then when you raised it a little bit, then everyone was just, or lowered it a little bit, and people were slightly below that, right? They're sort of interpreting these cow scores because I think I know the first precipitated withdrawal that I was treating when I administered buprenorphine, and the person got really sick. And she was, by the way, pregnant and 30 weeks pregnant. The first thing that I was told from my partner, it was Andrew Herring. He just said, first, get over your own existential crisis. Which was funny because I was definitely experiencing an existential crisis because I felt so bad. Because none of us want to give medication, then all of a sudden somebody like looks like they're sweating and pulling out their hair. I mean, it's pretty awful, right? And so I think that when you've seen that, even if it's just been once or twice, it's kind of like your reference. And so you're trying to avoid that. So I will say that in the emergency department, I think these are very well-meaning clinicians who just don't want to make people sick. And so it's like, okay, you're not quite ready take this at home when you're ready. But we also know that Dr. D'Onofrio's randomized controlled trials showed that we double the likelihood that somebody will remain in treatment if it's actually administered in the emergency department setting. So like it does make a difference. Like actually getting them on buprenorphine at that moment is really important. So we've been stuck in the middle here with fentanyl because heroin was easy. If I was starting somebody on buprenorphine and they were using heroin, I just say, hey, last use at night, come see me in the morning. We'll administer bupe or take your next one in the morning. No big deal, right? It's been trickier and fentanyl has been a little less predictable for people, but that's why direct to inject is a game changer because our highest risk people we can administer it and it just sneaks on. And then it was funny, I had a partner reach out to me because a lot of our street teams are doing this locally here. They're just giving this to a cows of zero. They're just giving it. And so I had one of our ER docs call and say, I've been seeing some more precipitated withdrawals um from the injectable bupe. And I said, can you tell me what that looks like? And she said, well, they all go home. Like before, we were having to admit a lot of people because they would get so sick. And I think it's just that continuous on ramp of the buprenorphine. They're just, even if it is sort of a rocky course, they're tending to respond well to some adjuncts and just tincture of time. So it's to answer your question, Jennifer, it's a really good way to go in the emergency department, which is why we came up with the algorithm. The next big step is just getting it on formulary so emergency departments can administer it. But yeah, this is why it's such a big deal because to get people from a cows of 4 to a cows of 8 is challenging. But if you can get them to a cows of 4 with just 6 hours, that's actually doable in the emergency department setting. So anyway, yeah,
Thank you so much.
just described the entire need for this. Yes.
We have time for one quick one. We're just about out of time. If anyone has a quick comment or question.
This is
Rusty,
Rusty.
yeah, go ahead.
Yeah, in a jail setting, I'm looking here at 3 days median stay to 12 days. If you had
Yeah.
3 days, uh, and you don't know if you're going to be able to get an appointment right away, could you just inject the monthly?
Yeah. Yeah. I mean, honestly, you saw the on-ramp there.
Yeah.
So yeah, there's a lot of people who are, actually even On Point has a whole algorithm like for just injecting the monthly. A lot of our street teams are doing that because the same reason they're not going to see people for a month. But even if you had 3 days, what we've been doing is you could even give them, if you're unsure, like if they've never had bupe before or something, you could do that 24 milligrams at a cows of 4, or even you might have some time for 8, but I definitely get them the monthly before they leave. Like you could do
Okay.
the initiation with 24, and then within a day you can get them to monthly, like within one day. So easy to
Okay.
get them. Yeah.
Thank you.
Mhm.
Thank you so much. So we've come to the end of our time. I'd like to thank you all for joining us. And of course, thank you to Dr. Campbell. We're so appreciative of you giving this great talk and sharing your expertise with the NJAX community. So take care, everyone, and see you at the next seminar. Thanks again.
Thanks, everybody. Thank you for having me.
Take care, everyone.